My name is Alberto, and I would like to be called Alberto if you address me today. I am a PhD candidate at Kent State University, as Jan said, and I'm introducing today my talk on translationality and relationality in medical interpreting, humanistic perspective. I will be discussing the following points. First, I am going to introduce the idea of humanization and its counterpart, the dehumanization, as an introduction to the humanistic models in medicine and medical humanities that lead to the understanding of a relationship-centered care, which is one of the cornerstones of my research. After that, I will be reviewing the affective dimensions of these models, what I call healing and care, through a literature review of medical humanities. And extracting some of the ideas from that literature review is going to take us to what I called the pedagogies of care, which is a combination of pedagogies that both address the teaching of meaning and also healing and caring. After that, I will introduce the title. You will get to know why I decided to use this title for the presentation and how this process reminded me of translationality and relationality in translation studies. And then I will end up with some closing remarks and some future directions for everybody to discuss at the end what we can do with this, okay, and why this is useful, why is this interesting. Um, the cornerstone of the philosophy of medicine is the patient's healing. And, and, and Pellegrino, who is the author who started this, argued that the philosophy of medicine is concerned with all the phenomena that are peculiar to a human encounter with health, illness, and the desire for prevention and healing. This humanization of medicine has taken different shapes in the philosophies and theories of modern scholarship. And humanistic medicine emerges as a medical practice that focuses on the whole person. And we talk about this in pedagogy a lot, right? Many of us, we talk about the whole student, the whole person. And in this case, it is just, it is a way not to focus on the patient disease only, but to include other factors. And in the past years, research and also some initiatives in public health and health promotion are pointing towards a holistic view of medicine. And holism in medicine is the treating of the whole person, taking into account mental and social factors. So drawing from this definition, the most recent research calls for the construction of a holistic framework that is useful for health promotion with clear and focused boundaries. Perhaps one of the most influential frameworks is Markham's comparison of the boundaries between the biomedical model of medicine and the humanistic model of Western medical knowledge. Moving forward from the notion that the patient is reduced to a diseased body part, to a physical body with a diseased body part, these humane models take a dualistic metaphysical position in which body and mind are considered complementary aspects of the patient. And this epistemology is based on a commitment to organicism. Here, the patient is more than separate body parts put together, right? This is an ontological shift from physicalism that incorporates subjective and human knowledge into the medical models. So, although the humanistic models share many of these objective features with the biomedical model, they also recognize what we call subjective knowledge, right? Subjective features. Because these humanistic models rely on practitioners' emotions and intuitions. And this subjectivity that comes from the practitioners, but it is also going to be important on the part of patients, as we will see, is not an impediment for fair medical judgment here, because when they are properly utilized, these emotions and intuitions enable a physician to access information about a patient illness and some things that might exceed lab results or quantified data. Um, the biomedical model situates the physician in a position of dominance as an authority figure that represents the figure of paternalism. And this suggests somehow a passive relationship with the physician, right? In the same way, we think about the transmissionist model of teaching, where there's this professor that knows everything and teaches everything, and we just listen. This would align with this paternalistic figure of the physician. And from the diagnostic perspective, this would imply that it's the physician, the one that chooses the treatment and the therapeutic modality, often with little patient consultation. And this has been labeled as Markham, as emotionally detached, concerned, which characterizes the biomedical model. And at the opposite end of this, we would find the empathic care as the focus for humanistic models. This empathic approach to modern medicine requires the patient to be autonomous and the negotiation of the choices with the practitioner. Therefore, the practitioner here in the humanistic model has no longer that much authority, and they become a co-participant with the patient and other health providers. And this highlights the central goal of humanistic medicine, which is to provide a balanced care between these two. It is not that we are disregarding the cutting-edge science that comes from the biomedical model, but we are combining there or finding a balance with cultivating a caring relationship as well. Mhm. The very need to advocate for humanization in medicine also points to its counterpart that we cannot disregard, and is the persistence of dehumanization. To strive for humanization implies acknowledging the dehumanization that sometimes it is linked to structural and interpersonal forces. It is not easy to operationalize dehumanization, but some say it is the denial of a distinctively human mind to another person. And this leads to diminished consideration of other mental states. This point is crucial for understanding the idea of empathy in healthcare contexts, as certain forms of dehumanization, where individuals are regarded as mechanistic entities, are closely associated with a reduction in empathy engagement, or what we call diminished empathy. Mhm. And empathy is a conditional value in patient-physician relationships, first examined by Castle, who argued that physicians must be adept at working with patients, taking histories, establishing rapport, providing empathetic support, and communicating effectively. So in modern medicine, therapeutic empathy is understood as a concept that includes not only understanding, but also communicating and acting in ways that maximize this therapeutic benefit of shared understanding. But achieving this mutual understanding is not always straightforward, as dehumanization cannot be conceived as diametrically opposed state to humanization. Dehumanization has multiple causes, and many of them extend beyond the patient physician relationship, such as the structural and organizational features of the hospital, psychological demands that are intrinsic to the medical profession. This is what we call functional and non-functional causes of dehumanization. So even though clinician-patient relations are rightly recognized as one of the most pressing public health issues, it is equally important to acknowledge the broader forms of dehumanization, their underlying causes, if these causes are functional, if these causes are non-functional, and the ways they are or not addressed in current medical scholarship. In other words, we can argue that humanization and dehumanization are in a state of flux, and they should not be understood as opposite settled states, but as changing, unstable processes that need to be understood in a continuum where different causes are constantly shifting the tension between these two movements. And only by doing so, we can work towards a model that is grounded in the most humanistic practice of healthcare. A model that is committed to challenge the factors that sustain resistance to a more humane vision of care. And you have relationship-centered care emerging in my literature as one of the main cornerstones in my research. Again, while a biomedical approach has prepared graduates for immersion in a sophisticated course of healing with positive health outcomes, high technology, and advancements, recent research, however, suggests dissatisfaction with medical services on the part of patients and practitioners. And I would suggest that it's not only recent research, but that we can also feel that in our environments, right? It's the case usually that we face this dissatisfaction with medical services. And this suggests that that this might be one of the reasons behind the emergence of a humane care, because this quality of care crisis can be attributed to the lack of humanization in medicine. But there is just not one antidote, unfortunately. The humanization of medicine is a hard task because the field originally paid insufficient attention to social dimensions. And although bilingual communication often calls for further research on the most multicultural aspects of medicine, the emergence of this topic in the literature requires a conceptualization, a reconceptualization, or at least putting concepts together and having a better structuring of knowledge so that we can work on models that can be applied to our field. As well as it is important to recognize the human and non-human agents that are involved in the process of healing and care. And this is what takes us to a very useful approach here is relational medicine, to understand the relations between all these human and non-human agents. This idea of relational competence originated in psychology, and it is an attempt to link communicative competence and interpersonal relations. In interpreting studies, this concept has already been applied. It's not that I am discovering the world for the interpreting people now. It has been discussed as interpreters' relational work, interactional competence, or interpreting as interaction. And the notion that interpreters can assist in establishing trust and rapport with the therapeutic relationship also resonates with research, with empirical research on interpreters as relational mediators in the therapeutic alliance. Some other influential frameworks focus on relationships too. For instance, relationship-centered care that acknowledges the importance of affect and emotions in relationships established across all participants. And I want to emphasize here all participants. The relationship-centricity, it is a key aspect for the purpose of this study because it emphasizes the importance of clinicians' emotions, not only in their relationship with patients, but also with other care team members. And it differs from patient-centered care in the sense that relationship centricity has an explicit recognition that clinicians bring their personhood into their encounter, which takes me back to the idea of the whole person, right? We are trying to bring the whole person into the equation, and relationship centricity seems like a step further from that patient-centered care because of this recognition of the personhood. Several healthcare systems across the US have adopted these training programs in relationship-centered communication that offer a combination of interactive lectures, demonstrations, experiential skill building, and guided feedback in small groups. This would take me farther from our rationale, but yes, this is a widespread integration of these approaches, and it has been linked to increasing satisfaction among both patients and healthcare providers, which leads to better health outcomes on patients. So understanding these and what these contributions are to relationship-centered care becomes essential for me as I try to identify which are the practices that contribute to humanism in healthcare theory and practice and education. And an investigation of these practices is the subject of a different study, but I am trying to summarize all of them here because the important purpose here is to look at those manifestations of humanism within the pedagogies that have been relevant for medical education and the pedagogies that we are using as well to teach medical interpreting. As a way to introduce my research problem, I wanted to propose, again, a situated learning for interpreter education. This happens when students interact with others in the same social context that they would be working at. And there are some studies that have been conducted previously on, for example, this study by Indira Sultanik in 2018 was an empirical study on medical interpreting training and perception of readiness. The perception of interpreting services managers of readiness as an attempt to bridge the gap between research and practice. This was very inspiring for me because I believe my research is also an attempt to bridge the gap between research and practice. And I aim to further contribute to the conversation on contextualized, humanized medical interpreting training, focusing now on the relationship building aspect of the profession. So my research gap, and I just realized that this looks exactly like the Gap logo for the clothing store, but I am not being sponsored. My research gap is that the question I kept asking myself is how can we educate on the relationship aspect of the profession if we disregard many of those aspects from the medical humanities and medical theory that we are not incorporating in our pedagogies. So understanding the aspects that contribute to the humanization and dehumanization of the profession, it is the aim of my study. And I articulated these two research questions. The first one would be, where are the conceptual affordances and practices of humanism applied to medical interpreting? And the second research question, when we look at the pedagogies, is how is this humanism or these humanistic values represented in recent influential pedagogical models that are useful for relationship-centered medical interpreting curriculum? So the first question that is somehow taxonomic, it will be answered through a conceptual discussion that I'm going to introduce now of some theories and philosophies in medicine that discuss humanism at their core. But what connects my research question one with my research question two is that for these theorizations to reach training status, for these theories to be enacted in pedagogy, we must aim for conceptual clarity in humanistic theories. And that's why we are seeking with the second question, trying to identify the most common elements of humanism in our pedagogies. And I am going to take a sip of water now, I'm sorry. Exploring the medical literature, one of the most important things I found is health communication as a way to support people to adopt healthy behaviors. And this health communication scholarship points towards culturally competent care. But it's not only about sustaining those healthy behaviors. It is a wide array of practices, such as providing patients with exposure to health information, risk communication, the education of consumers. And this is just an example of how communication happens in relationship building for the delivery of appropriate health outcomes, right? A very interesting concept I found here is the concept of influence that was operationalized by Epstein and Street in patient-centered communication, so that the relationship between all the voices involved in healthcare is well understood, as well as how much they influence each other. They argue that clinical encounters are processes of mutual influence, in which all the parties involved have the same influence on each other, so that conversations are considered exercises of mutual persuasion. And there seems to be a clear connection here between therapeutic empathy and mutual persuasion, because mutual persuasion in patient-centered communication is presented in the shared decision-making process to produce high-quality decisions. But to accomplish this shared understanding, we need to understand this as an exchange that happens with the implications and contributions of fully informed agents who can make ethically aware decisions. And fully informed agents, what are those agents? What are these agents? There is some scholarship in the medical field that recognizes all these multiple voices. And these authors, Parker and Ellington, they point to similarities and challenges for the range of voices that are critical to the patient and family healthcare experience. Nurse aides, physician assistants, social workers, pharmacists, but where are the interpreters here? They somehow appear in some of the literature as cultural mediators, are interpreters, but are they fully informed? Addressing the complexity of healthcare communication systems, there are some subfields such as bilingual and multicultural health communication that are very helpful for us. And the term patients with limited English proficiency, that again aligns also with students with limited English proficiency in the second language acquisition field. It stands for healthcare users that might experience difficulty communicating effectively in English. And this leads to face some inequalities in medical service that can lead to poor health outcomes. When language barrier exists in provider patient communication, there are studies that show that a patient is less likely to receive more diagnostic testing, so to be exposed to more tests, less likely to receive preventative care and follow-up appointments, less likely to understand healthcare providers' instructions. And this reminded me of all the numerous studies that attempt to establish a link between health literacy and health outcomes. Health literacy can be defined as the skills that are needed to not only to understand, but also to apply the information about health issues that have an impact on health behavior and outcomes. So I have a couple of empirical studies here. Sentel and Brown found that patients with lower health literacy were at a higher risk for poor health outcomes, and that low health literacy Latino patient might be also more prone to medical errors. These findings call for the development of effective interventions to improve the quality of LEP patients. And an example of this is the use of trained interpreters in healthcare settings. These interpreters are in a critical position to assist patients. However, their role has been controversial in nature since the beginning of our scholarship, and it has been discussed in literature, the role of the interpreter, but mainly because of its impact on what we call patient autonomy. Despite the significant of studies showing that professional interpreting service are good for the quality of care, for the treatment process, for the health outcomes, there are also some researchers that have been questioning these interpreters' active involvement. And this conclusion derives from the traditionally ideology, like from the traditional ideology of interpreters as conduits. However, this model has been challenged in the past decades several times and is now understood that an interpreting is more than using those equivalent terms, right? Or understanding that yes, interpreters can be conduits, but that is just one of the multiple roles of the medical interpreter. In language and in social interaction, we have to agree on the fact that human communication exchanges are not only linear, but dialogical and co-constructed. So you see how many of these words keep repeating themselves, and that is my attempt to find connections between our literature and the medical field literature. And when it comes to the interpreter's presence, for communications to be effective in these encounters, we need to understand that each individual is going to bring to the interaction a set of dispositions, perceptions, and beliefs. And each of these individuals become a key player in the construction of meaning, interpreters included. That's why we also talk about the visibility of interpreters that are no longer invisible, because it's essential that interpreters are visible to communicate affect nuances, establish trust, and facilitate mutual respect. Angela Lee also states that a medical encounter must be responsive to the patient's emotional state and concerns, communicating affect nuances, establishing trust, and facilitating mutual respect. As I said, this is what in pedagogy, it has been understood as a situated practice, because we are calling a shift from something that is a descontextualized assignment or decontextualized practice towards something that is more situated. Why situated? Communication is message-centered, and the message can be understood by analyzing the form and content of the message situated in context. So this is essential to understand interpreting as a situated practice, to understand the human condition of the interpreter. That's the only way we can reach that human condition. And in recent medical interpretive scholarship, this has been discussed in bringing and drawing from the medical field and the medical humanities, and the lines that separate some of the concepts, such as affect and empathy, can be blurry. But Gavioli and Merlini argue that the tone of the central issues is to provide interactional space for patients to express their feelings. And empathy, it is a specific case of emotional responsibility. This definition of empathy, that is not affect, that is a specific case or action of emotional responsibility, shows that empathy can be an emotional response and a cognitive response, because it accounts for the balance between maintaining that self-awareness and that self-judgment and the ability to move back and forth between one's world and that of another. So empathy, again, is situated here at the center of the interpreting event as a value that is needed for patients to produce an autonomous response and for interpreters to manage affecting doctor-patient interactions. As a way to prematurely respond to my first research question, after we have reviewed all this literature of all the fields and subfields in medical theory and medical humanities, my answer to what are these conceptual affordances is that there is a relationship between health literacy, how much we know, how much we apply the knowledge we have about health and health outcomes, and that this is of interest of the interpreters as well, because of influence, the concept of influence and how everybody influence each other in the process of achieving shared understanding that can only be achieved with fully informed agents. And empathy becomes now the keyword of my research because of how empathetic support and therapeutic empathy have beneficial outcomes for patients. So while this conceptualization might take me farther from the rationale, I wanted to try to summarize it here so that we can recognize the most recent developments and see how these recent developments are intertwined with the prevailing notions of medical interpreting theory, practice, and pedagogy. In other words, I don't think humanistic health and medical interpreting are far from being disconnected. They are not. They are far from being disconnected. And if we aim for this conceptual clarity that I was trying to achieve through this literature review, we can argue that interpreting studies would be informed by a humanistic approach to curriculum and education that encompasses all these advances. This discussion of multidisciplinary literature in the previous chapter has a purpose, and the purpose is to provide conceptual clarity and to understand the structure of knowledge better for further discussion and implementation of humanistic approaches in pedagogy. I labeled all these pedagogies of care. And what I'm trying to do here is to draw connections and identifying key elements for a humanistic approach to curriculum that emphasizes the affective dimensions of learning, that doesn't disregard the biomedical model or other dimensions of learning, but that includes these affective dimensions. And one important pedagogy for me here has been the pedagogy of care by Nell Noddins, that argues that caring is the foundation of morality. Nell Noddins distinguishes four components in the pedagogy of care: modeling, dialogue, practice, and confirmation. And these four components directly align with some of the specific skills that are needed in healthcare interpreting training and practice. This suggests that educating students from the ethics of care so that they care for themselves as much and they care for each other too. It might be one of the most efficient ways to prepare multilingual learners for the professional task. Caring is healing. That's what the activist and philosopher Nell Noddins says. Another important pedagogy here is culturally responsive pedagogy because it addresses the cultural biases that can happen in healthcare delivery for people with diverse cultures or diverse belief systems. This pedagogy is very interesting for medical interpreting because it examines the way people perceive health and illness, depending on their belief system, on their background, and it responds to and the way they respond to symptoms, the way they respond to treatments. According to this approach, we have some strategies here that are also present in some of our pedagogies, like role modeling, immersion, anthropological approaches, and template approaches, and critical consciousness. The justice component of this pedagogy is also important because it's based on commitment to social transformation and equity through education. So again, I think there are so many elements that we can take from these pedagogies that have been mostly applied to medical education and start working on a more humanistic module. My third pedagogy that I chose is flux pedagogy because it emerges right now in the present moment, in a time of radical flux where there's global displacement, people are looking for jobs, we're juggling employment and family responsibilities, worried about our health, worried about public health. So this time produces visibility for the need of a more humanizing education. And these are some of the values of this pedagogy, a pedagogy that is based in the inquiry and the power of asking questions, and that is trauma-informed, and that is student-centered as well. It somehow has a critical component, it incorporates storytelling for the purpose of integrating racial literacy pedagogy and race-based pedagogy. Situated learning, which is a pedagogy that I have already mentioned, also touches on these notions because it is defined as learning happening in contexts that reflect the way knowledge would be used in real life. As discussed previously in the literature, Angelelli, among others, argued that interpreting is a situated practice. And Sultanik, Indira Sultanik, in her previous work, also defends the position that without a situated learning module, medical interpreters might not be fully prepared. So this is my attempt to come back to the idea of how we can fully inform the agents. They need to understand the whole medical domain and the whole event in order to help patients and physicians in clinical interviews, history taking, physical examinations, many things that belong to the medical profession. So that can be achieved through shadowing and mentoring and simulation-based learning and professional experiences as well. The last thing that I wanted to make a connection with is an forthcoming project that I'm working on with Dr. Weshman that is called Cosmopolitan Pedagogy, based on this concept of cosmopolitanism, that is a difficult word, I'm sorry, as a literacy of human connection and agency. And some of the values of this pedagogy also aligned with the values of the medical humanities, in the sense that learning is dialogic, it teaches the value of valuing, and gives a space for the alternative voices and the underserved communities, and focuses on the interconnectedness of the local and the global. We can also see how it emphasizes ethical obligations and engagement with the cultural other, and challenges the notions of stranger and normalcy. So in putting together these 5 pedagogies is what helped me understand the key elements that are intertwined and that are connected within the pedagogies. And I decided to summarize the elements that I just discussed in 3 categories for relationship-centered pedagogy. First one is modeling approaches. Modeling is the way we show ourselves to the students, and I think it is important to show humanistic values. Immersive approaches, it is the second category I came up with, and then role-taking approaches. Modeling would refer to that, again, to showing those humanistic values and engaging critical dialogue about stories or practices that are known or accessible for the students. And immersive approaches are important here to redesign opportunities for service learning and immersion in real-world simulated tasks that will facilitate different perspectives about the practice. Role-taking approaches, it is a step forward from role-playing, in the sense that these approaches suggest the internalization of the roles for students so that they gain agency and spontaneity in their roles. Without that agency and that spontaneity, it is very hard to build relationships in the classroom, and it would be hard for them to build relationships in practice. So I suggest this step further from role-playing so that they can aim to build relationships through the roles they internalize, they take, because the aim here is to build relationships again. And putting together the interrelated dimensions of these pedagogies and some suggested practices, I would like to brainstorm here, and hopefully brainstorm with you later, some of the practices that can help addressing all these interrelated dimensions between medical humanities and the pedagogy. For example, something as easy as demonstrated kindness. It sounds easy. It might not be easy in every educational context. Can be done through modeling, through the way you portray yourself as an instructor. That is a way to show openness too. And this importance of asking questions and um, being critical about the situation can be achieved through communal restoring or free writing as well. Um, since learning is dialogic, we can also aim for semi-structured dialogues and a job shadow. And job shadowing is also a good practice, a good modeling approach, which means that this might be more focused on the part of the instructor or the educator themselves, because it is modeling. It is what we how we engage in learning, and these are some of the activities that I suggest that should come first for us as instructors and educators. So that if we engage in this, we are providing students with an example of how to engage in those humanistic values. When it comes to immersive approaches, the first thing that comes to my mind is service learning, right? And having students go help the community and do service for the community. And that can be achieved through the visit of health centers. Virtual exchanges are also very important to what I mentioned in cosmopolitan pedagogy, or engagement with the cultural other. But it's not always that easy, and sometimes we have to simulate, right? But we can simulate community centers instead of simulating only what happens in the doctor's office, so that we can provide students with a different perspective of how we can immerse in the medical reality. The ideal is service learning and bring these students to real life practices, but we can also simulate other things that are going to give us more knowledge, and our students are going to be more prepared for the medical reality. And lastly, when it comes to those role-taking approaches, it comes with having a critical consciousness about what we're doing and to internalizing different roles. An example of this is what I mentioned before, role taking. So in my classes, for example, instead of providing students with roles that they can play, I assign a role, and and from that moment they start a process of research about the implications of that role. Who is that person? Who am I as this person? So that they end up speaking spontaneously as a doctor or as a nurse or as a patient instead of playing those roles. I believe that internalization of roles, it is very important for them to see themselves in the real life setting, because sometimes playing roles can restrict what the whole person of the student and what they are bringing to the classroom and then to the practice. Another idea I have here is in what aligns with the brave space pedagogy in flux pedagogy, which is norm setting dialogues. It is important also to have our students have a dialogue that, for example, where they are discussing all the the guidelines for Latino patients in a specific hospital, or where they believe where they belong to spaces where they have an activist position on how those norms are going to be established and how those guidelines are going to be followed. That gives them that autonomy and that agency that it is important for these two. So now many of you might be wondering, why did you choose translationality and relationality as your title if you haven't mentioned it yet? And it is because this is a recent idea that I came up that I encountered as I was progressing on my research, because there's many similarities between in this balance. No, we need to find a balance between the biomedical model, the humanistic model, and the meaning and the caring. And over the past 2 decades, translation and interpreting studies as a field have undergone these shifts in many of their theories. Earlier models tended to conceptualize translation and interpreting as an act of linguistic equivalence, but we know now that thanks to the sociological turn, we have a broader understanding of mediation that is socially situated. Translationality refers to the potential conditions and processes that make meaning transferable across linguistic and cultural boundaries. It shows that translation and interpreting are not neutral, but dynamic and situated negotiations of meaning. And in interpreting studies, specifically translationality draws attention to how interpreters work within and against institutional norms and power asymmetries. From this perspective, the interpreter is not just transferring words. It is co-creating understanding through choices informed by the ethics, by the context, and interaction. So translationality invites us to have an exploration of how meaning travels and transforms and how it adapts to new relational environments. No, so complementing this, we have relationality. It's not translationality versus relationality. For me, it is translationality and relationality, because relationality focuses on these interpersonal dimensions of interpreting, such as empathy and attentiveness, and the main focus is the quality of the relationships. So understanding that emotion, embodiment, and interaction is important can take us to draw a connection between those two, or at least put them together, because them taken together offer a complementary holistic lens. And that is what we are trying to achieve, that holism that is present in medicine as well. Translationality highlights how meaning becomes transferable and how it transforms, but relationality reveals how that transfer of meaning, or how that meaning is always supported and sustained by human connections. By acknowledging both the translational and the relational dimensions of the interpreter's work, we can better account for the complexity of interpreting as a deeply human activity that is socially embedded, but that also has that also gives a lot of importance to how meaning is transformed. So my last remarks, I know I'm running out of time, is that bringing translationality and relationality into the equation here, it is important for me to understand all these concepts in a state of flux, where they are constantly changing, and that we cannot forget about one or the other for us to come up with new humanistic pedagogy. So we have translationality and relationality as something that originally could be opposed, but it's the same thing that happens with the biomedical model and the humanistic model, or even the same with dehumanization and humanization. But can we oppose meaning to caring? I don't think so. That's why the main idea of my pedagogical approach is to provide meaning and to provide care, and to focus on the good parts of each of these theories and discipline and theories and construct that somehow have been opposed in the literature, is that we understand that it is a state of flux that is constantly changing, that we cannot understand humanization without dehumanization, that we cannot only provide students with a relational competence if they don't understand the high quality treatment and technological innovations of the biomedical model, that meaning is as important as caring, and that's how I aim to combine the both of them. Not to mention the limitations of my study, because these are many, I would like to say that I'm open to discuss more pedagogies and more ideas if you know any other pedagogies that incorporate these notions, as well as I believe one of the most interesting future directions for this preliminary study and conceptualization is to understand the educators' attitudes, beliefs, and practices in humanistic in education. So what are the values? What are the practices? What out of all these concepts, what is it being applied or not? How is it represented in the teaching? In the same way, along the same lines, other empirical studies can point towards translation students' perceptions. So if we implement a module that is based on these suggested practices that I showed on the tables on the last slides of my presentation, if we implement a module and we get feedback from the students, we can see how they perceive humanism in education and in medical environments. I also think that it's important for medical education and for medical students to be aware of this because of what we call translation and interpreting literacy, that how much providers know about translation and interpreting, how much everybody knows in the clinical encounter as translation and interpreting and the impact that has. So I think it would be very interesting to look at specific modules for medical education and how they can incorporate these notions too, so that they are aware of the profession of translators and interpreters. Another line of research that I think is closely related to this one is the experience of heritage learners as cultural brokers or child language brokers. I think it could be very interesting to see in a heritage language classroom how this the experience of heritage speakers is very valuable to contribute to the co-construction of knowledge through these suggested approaches. And I also believe that this has applications at all levels, and that is the good thing, that we can start working on just one of the suggested practices and incorporate it in our classroom, or we can do a task-based module drawing from many of these practices, but this can also be taken to the level of curriculum development, and that is what I believe this preliminary study opens the door for many research to come. Thank you for listening to me. This is my email in case you want to contact me, and I would appreciate any questions, comments, suggestions now. Thank you so much.